All right, let's get started, and participants can join us as they're ready. Hello, everyone, and welcome. My name is Ann Sasson, and I'm the Program Director for Dartmouth Center for Global Health Equity. I'm pleased to welcome you to the first Pandemic Partnership for Equity of Information webinar. Today's session will focus on protecting the health workforce and will be led by Dr. Elizabeth Talbot. Dr. Talbot is professor at the Geisel School of Medicine at Dartmouth and a specialist in infectious diseases. She's been an outbreak investigator for the U.S. Centers for Disease Control and Prevention, the World Health Organization, and the New Hampshire Department of Health and Human Services, where she currently serves as the Deputy State Epidemiologist. Before we get started, I'd like to let you know that today's session will be recorded and posted online. A brief document summarizing the information will be shared in English and Spanish with all participants. If you have a question or comment, please insert it into the comments sections. We are able to take questions in English, Spanish, and French today. Thank you, Dr. Talbot.
Thank you very much for the invitation to provide this information. I approach it with a great deal of humility as on the front lines in the United States, we have our own very significant struggles with making sure that the personal protective equipment and training for such is readily available to our protected health workers. So let's learn together. The session objectives are to make sure we understand that there are indeed risks to healthcare workers because of the evidence of nosocomial or healthcare associated transmission that has been occurring during the COVID-19 pandemic. I'd like to review the personal protective equipment or PPE recommendations that exist and then present strategies for prioritizing the use of this limited resource for healthcare workers and first responder workforce. I'd like to review strategies that we found helpful for securing and conserving PPE, especially as they might be translated to resource constrained settings. And then talk about some other practices that minimize risk to healthcare workers and first responders. So let's get started with affirming that there is indeed risk. Healthcare workers are indeed on these front lines of fighting the COVID spread. Without appropriate personal protective equipment, of course, their risk for acquiring this disease themselves is much greater. We are greatly challenged by this novel virus for the fact that we recognize it can transmit from person to person even without the presence of symptoms or before the symptoms occur. As one example of a jurisdiction that has been publishing their proof that there is a disproportionate impact on the medical personnel, it's noted that 13.6% of Spain's 47,000 total cases were among their medical personnel. This represents about 1% of that health system's workforce. So this is a tremendous impact that's happening in countries that are impacted. To review the mechanisms of the SARS coronavirus to transmission and also how the healthcare worker may find themselves at risk, I'd like to make a very strong statement that this virus predominantly transmits through the droplet route. This refers to small particulates that are ejected when a person sneezes or coughs. So droplet exposure is the main mode of SARS-CoV-2 transmission. These droplets, again, ejected during a cough or a sneeze, so predominantly from a symptomatic person, can travel on average less than 6 feet because of their size and trajectory. There are references that are coming of experimental generation of such droplets, showing that some of them can go farther than 2 meters or 6 feet. But in general, this is the majority that that right now is being demonstrated in our healthcare settings. There has been a lot of question as to whether this virus transmits through the airborne route, that is similar to tuberculosis or measles. Can this virus suspend in 1 micron or less droplet nuclei that suspend in the air for prolonged periods of time? This appears to be not the predominant way that this virus transmits. However, we do recognize airborne transmission occurs during aerosol generating procedures. I'll abbreviate this going forward as AGP, but this is when we do something to patients in healthcare, such as intubate or provide them with nebulized medications. We also recognize that this terrible virus can transmit through fomite transmission. So this refers to when a patient contaminates the environment by their coughing or sneezing, and then someone comes along, touches that contaminated surface, and inoculates their own mucosal membranes by touching their eyes, nose, or mouth. We have a lot to learn about how long this virus can survive on the environments, especially in our healthcare setting. But experiments that are done in highly controlled circumstances where the humidity and temperature have been tightly regulated, we see that the virus might survive as long as days on certain surfaces. Fecal transmission has been postulated because in early studies in China, viral RNA was identifiable in the feces of patients, especially in the later course of their illness. However, this appears to be a very small component of the ways that this pandemic is propagating. It's an important principle where we're all learning that just because you can find the virus's RNA through the predominant testing strategy does not mean that's virus that can infect other people. So right now, we believe that fecal transmission is theoretically possible. It may represent a greater concern in settings with poor sanitation where there is greater fecal contamination of environments. But all said, this seems to be a very small contribution to the propagation of this pandemic. Again, I'd like to go back to the important feature that it is it is symptomatic patients who are transmitting through the droplet route predominantly. And this informs our recommendations for personal protective equipment. One of the most important things that can happen in every institution around the world is to begin greater attention to what we refer to as standard precautions. So the features of standard precautions are well known to you, but I review them as you consider the way that this virus transmits and how these may help prevent transmission. So for example, hand hygiene is absolutely critical. This can be accomplished through soap and water or alcohol-based hand rubs or alcohol-based solutions. So considering the potential of fomite transmission, for example, frequent hand hygiene will prevent a person from being able to inoculate their mucous membrane because it's only with clean hands that they touch their face and potentially contaminate themselves. Of course, we use personal protective equipment, but only according to the risk. That is where in the hospital, which patients, and under what procedures. And this is what we'll talk about for the remainder of the talk. Also, respiratory hygiene or cough etiquette, as it's often known, is an important standard precaution. So everyone from child to doctor to patient to every member of your healthcare staff should be reminded of appropriate respiratory hygiene, which means coughing into the crook of their arm as opposed to contaminating their hand, and certainly capturing those droplets as opposed to just sneezing or coughing outright. Safe injection practices are an important part of standard precautions, sterilization, disinfection of medical devices. This again speaks to the potential of reducing fomite transmission. I'd like to make the comment that this virus appears to be fragile. So this is one thing in our collective favor, that is that routine cleaning can remove this virus easily. We don't need to use special cleaning procedures or equipment in order to clean our environment and reduce fomite transmission. So let's talk now about the commonly given recommendations with regards to personal protective equipment, or PPE. Here shows the preferred and acceptable personal protective equipment. Healthcare workers in contact with suspect or confirmed COVID-19 patients should wear gowns, face masks, eye protection, and gloves. These pieces are shown in the pictures below, and they can come in various forms. So I'd like to make several comments about these as shown, and will then repeat this as relevant going forward. But an isolation gown serves to prevent contamination if there's active sneezing, coughing, or procedures that generate aerosols. These are cloth or reusable coveralls or what that can be taken off and then cleaned after contact with the patient. There's considerable controversy and discussion about whether it is most appropriate to use a high-level respirator such as an N95 or a routine surgical or face mask for care of a patient. In the very beginning of this pandemic, when it was not well studied, we defaulted to the highest available level of personal protective equipment, including the N95 respirator. But as well known by this audience, these are more expensive and more uncomfortable to wear for prolonged periods of time, and also may render the wearer vulnerable to self-inoculation. That is because they often require more handling than a healthcare worker might contaminate their fingers and then actually inoculate themselves by the use of this device, which has to be fit tested. These have to be only worn by people who have been tested to make sure that they fit correctly. Otherwise, they really don't help as they're intended. But the most important feature that has emerged over the course of this pandemic is, again, that the predominant mechanism of transmission of this virus is by the droplet route, and therefore surgical face masks are appropriate for routine care. Currently, N95s are recommended for only aerosol generating procedures in settings where the healthcare provider is trained in the use of the higher level respirator and also previously fit tested. Keeping with our theme of the fact that there can be fomite transmission by self-inoculation of mucous membranes, and also generation of droplets that transmit through the air toward the healthcare worker, it's also extremely important to embrace the need for eye protection. This can be accomplished in several ways that I'll provide graphically in a moment. And then, of course, gloves. So these are intended to prevent any virus from being on hands directly and allowed for self-inoculation. This is a busy graphic and only serves, I think, as a highlight of some of the ways that we put the PPE ensemble together. I'll make a few comments about it, but suggest that it serves you to adapt to your own setting as appropriate. In the first row, this speaks to the circumstance where a healthcare provider is conducting an aerosol generating procedure, such as intubating a patient. And this is whether the patient is suspect with COVID-19 or actually confirmed by a laboratory test. This is the case where a higher level respirator is appropriate. So an N95, for example. A healthcare worker should protect their street clothing, their scrubs, or their personal clothing with the use of a gown. They should be gloved. In some cases of a heavy environmental contamination, an apron may be appropriate, and also eye protection. In the second row, this is direct patient care to suspect or confirmed patients, such that the healthcare worker may touch the patient, help them with bathing, feeding, putting on oxygen, providing medication, gown, gloves, mask, and face protection. If the healthcare worker is able to stay 6 feet beyond the presence of the patient and is anticipating no direct contact, most recommendations are that a medical mask alone will be sufficient, based on that principle that this virus predominantly transmits through the droplet route. We have to protect the full workforce in our healthcare settings, such as those persons who have to clean the room or the bed of a patient. And these are the recommended personal protective equipment as shown in this fourth row: a gown, gloves, a medical mask, and face protection, eye protection. We are prohibiting persons from coming in to visit patients who have confirmed COVID-19. This speaks to family members or friends coming in to visit a patient. It's a terrible time in our societies where, for example, children or people at end of life cannot have their loved ones present, but this is what we're all grappling with. If, for compassionate reasons, you elect to allow a patient to have visitors, then the recommended personal protective equipment that you provide to that person is gown, gloves, and medical mask with some training on the use of these. And also I'd offer to you consideration that this may be a time to restrict visitation. If someone is handling actual respiratory samples, for example, for the purpose of testing, the personal protective equipment is similar with regards to gown, gloves, mask, and eye protection. And then I'd like to also make a statement regarding what we call universal masking for persons who are not necessarily in the area of direct patient contact or patient care. So this is an important strategy that's emerging globally to try to interrupt transmission of this virus in our other non-healthcare settings. I'd like to make this statement regarding eye protection, which I've referred to several times. This is being accomplished in several different ways. Remember, the goal is to prevent the droplet from landing on the mucous membranes of the healthcare worker, or preventing the healthcare worker from using contaminated fingers to touch their own mucous membranes. So this can be accomplished by a face shield, an eye visor, or goggles. As again, well known to this group, goggles can be difficult to wear for many hours at work. Sometimes they fog up. They don't always work well if the healthcare worker is wearing glasses. So you need to find probably what's right for your individual healthcare worker. I'd like to say in the strongest possible terms that it's not simply about getting these pieces of equipment to create this ensemble, but that there must be training in the appropriate use. So errors in doffing PPE, that is taking the PPE off, are very common, and they contribute to the spread of COVID-19 and other infectious diseases. I'd like to make the parallel argument that this was the cause of many of the infections that occurred during the Ebola epidemic in West Africa. The donning has to be done correctly. That is, putting the PPE on has to be done correctly. But when you think it through, the reality is that it's the contaminated PPE being removed that gives an opportunity for the healthcare worker to contaminate their hands and again, then touch their eye, nose, or mouth. So it's critically important to review this. So I'm suggesting that part of this program to provide PPE appropriately to your staff includes just-in-time training to all staff members on donning and doffing, especially when they are unfamiliar with the PPE. We find that although it seems intuitive, and people sometimes, healthcare workers sometimes don't want to admit they're not quite sure how to put gloves on. They're not quite sure how to take their mask off. So we assume nothing. We assume that everyone needs the entire training so that we can avoid having our vital healthcare staff become infected with this virus. We don't forget either the environmental staff who are doing the cleaning of our facilities, because they are also in PPE, possibly for the first time in their lives. And so here, just-in-time training is provided. One and done training is never enough. Strong suggestion emerges that you adapt whatever job aids, whatever posters you have available to you, and I'll show you several, that remind staff of donning and doffing, and also captures new staff who may not have benefited from your just-in-time training. General principles about the use of personal protective equipment include the vital importance of hand hygiene. This must be done before putting PPE on and also after taking the PPE off, before there's an opportunity to touch themselves. Remove and replace any damaged or broken pieces of reusable PPE so that they can be repaired or discarded. The healthcare personnel should be instructed to remove all PPE as soon as possible after completing patient care and avoid contaminating the environment further outside the isolation room. So there needs to be receptacles for the disposable PPE or receptacles for those pieces of the ensemble that needs to then be laundered or cleaned in a unique way, because you can imagine that these are now fomites themselves that should be handled as such. So one of the most important processes within doffing is to discard these items and perform hand hygiene immediately following removal of the PPE. There are many just-in-time videos to help you do this for your staff. This is one that we like very much. This is put out by Emory University, and this shows how to don or put on droplet contact precautions with eyewear. So this is appropriate in the era of COVID-19. To the right, you see the job aid that perfectly mirrors the video, and I think has been a very useful combination. I know that these are available also from World Health Organization, and also it's important that you find the video that shows the exact product that you're using to reduce any chance for error, and also, frankly, to reduce the anxiety that healthcare personnel experience when they're being instructed in one thing, but being asked to use something different. This is the doffing video on the left and the accompanying job aid on the right. The reference is shown at the end of this presentation for you to consider use in your own setting. As promised, I'm coming back to an emerging concept within areas with mature epidemics, and this is that which is referred to as universal masking, and this accomplishes source control. So these are somewhat new phrases within our parlance of battling this infection, and this refers to the practice where, if possible, all staff should wear medical face masks, not N95s, in healthcare settings, including non-patient care areas, And this is intended to minimize the potential exposure of SARS-CoV-2 to coworkers and other patients, uninfected patients, during the period when these healthcare workers may be pre-symptomatically or asymptomatically shedding this virus. So there's a lot to unpack here. This is a significant change in our processes. So as we have increasingly recognized that part of what is driving this global pandemic is the fact that people can seem perfectly well before they become ill, and they're shedding virus in the environment at a high level, the use of this mask is to prevent them from sneezing or coughing in their setting and putting virus out there, and also from contaminating their own hands and contaminating the environment further. So we are now extending this to public use. I'm sure many of you have seen pictures and videos of this emerging globally, that the public is being asked to wear universal masking. And this is, again, to protect those around the person wearing the mask, not the person wearing the mask. So you see, this is being accomplished in the United States with a mandate to wear a cloth face covering, as we are in a shortage of the commercially manufactured medical grade masks. So people are wearing bandanas or homemade cloth masks to try to prevent further spread in the environment for pre-symptomatic or asymptomatic shedding. So moving to the next topic, these are strategies for prioritizing these vital and limited PPE in our environments. We must prioritize them for those who are most at risk. So if you are, as we are, limited in the amount of PPE you have, then it should be reserved for aerosol generating procedures, for those who are conducting high contact care, such as direct contact and within 3 feet of a patient. It should be preserved for people who have prolonged close contact, such as often the nurses and physicians who are working directly in the wards where these patients are congregated. It should be reserved for essential surgeries and procedures where non-essential surgeries and procedures are suspended. And then we would prioritize the use of PPE, of course, for those care activities where splashes or sprays are most anticipated. Let's review strategies for obtaining and then conserving the PPE in resource-constrained settings, but really everywhere. Again, I approach this topic with humility in that we are also faced with an extraordinary limitation of our personal protective equipment. So first, securing the PPE. Everyone is working closely with their supply managers to identify vendors and to secure PPE. We have taken a very difficult strategy of canceling all elective or non-urgent procedures and appointments that require the use of this vital PPE so that it can be diverted for care of patients with COVID-19. We have been collecting PPE from other somewhat unexpected providers. Sometimes facilities have this in storage, and we are taking it into our hospitals to care for the ill COVID-19 patients. We've discovered that laboratories sometimes have stock of PPE that we've been able to take into the hospital setting. Dental practices, which are now closed, often have PPE to identify. Private pharmacies sometimes have masks. I've been surprised that our veterinarian colleagues who have reduced their practice have stock of this. So we have a large university veterinarian hospital, and we have taken their PPE for use in our own healthcare settings. Sometimes industry, like mines or construction, have particulate respirators to avoid inhalation of dusts and those can be taken into the healthcare setting in many circumstances. In the United States and other developed countries, we became aware early that the public was purchasing and stockpiling because of the unknown pandemic emerging. So we have made a public request that these be redonated to the healthcare setting, and we've had a wonderful outcome from this. There's been a large number of donations made from the public space. We also recommend that wherever possible, you obtain reusable PPE so that you can wash it and reuse it, rather than continue to try to source it from the private industries where it can become very difficult to do so. In parallel, there's a strong recommendation and clear recommendations to try to conserve the PPE that you have secured. So the training becomes very important, right? So the healthcare workers have been told and need to be told repeatedly, avoid touching it, which reduces the damage and sometimes the contamination that can occur. You have to maximize the use of engineering controls, and that refers to the use of barriers between suspect confirmed patients and non-COVID-19 patients. But it also refers to cohorting patients, as you are used to doing on wards, for example, for tuberculosis. Institute administrative control to minimize patient contact, to create space in our waiting rooms, and minimize the need for use of PPE under those circumstances. Extending the use refers to ways that we're learning can make each piece last longer. So certainly early, we embraced the recommendation from our federal agencies that it's okay to use the PPE beyond the manufacturing shelf life. There were tests done on many of the vital pieces of PPE, and the shelf life appeared to be too conservative, that these were they were still completely functional even when they had passed their expired date. We make the statement that the extended use of PPE is better than reuse. So this refers to the fact that the healthcare worker does not take the PPE off, store it, and then put it back on. So again, wearing it continuously is better than taking it on and off and on and off repeatedly. This preserves the use and extends the life of the PPE. So for healthcare workers working with SARS-CoV, you can reuse some of it as long as it's not soiled or ripped. And we have to remind our well-meaning healthcare workers that they should not share PPE one to another. Healthcare workers working with patients who have not tested positive should, of course, change the PPE between so that they don't infect a patient by virtue of contaminated PPE. One of the more important strategies we've all adopted regarding extending the use of masks, the face masks or N95s, and the eye protection is that this should be worn together the entire shift of work. That is not taken off and replaced. It reminds me again to say that this is why an N95 is not favorable. You likely all know how difficult it is to wear an N95 for 8, 10, 12 hours continuously. So the face mask appears appropriate for that, and then the eye protection. With that, there's a video that shows you how to extend that wear of face and eye protection as a single ensemble, the job aid to the right. However, there needs to be the reminder to healthcare workers still to change gloves when possible and to perform that hand hygiene. I have found a tremendous website and I want to share it with you. This is on the CDC, the US Centers for Disease Control and Prevention website. And the reference is included in this PowerPoint deck for you to look at closely. This is the screenshot of it, and it is strategies to optimize your supply of PPE and equipment. So each of the bars on the right are an active link to strategies to reuse eye protection, isolation gowns, face masks, N95 respirators, and other pieces of equipment you may use under certain specialized circumstances. But many of these strategies are quite creative and are evidence-based as safe strategies for reuse and extending and also substituting commercial grade for other types of equipment. There are other practices to minimize risk to healthcare workers and responders. This could be hours of discussion, but I do want to make a few comments in the scope of this session. I come back to this notion of universal masking or source control, and this must not be confused with personal protective equipment. I'd like to say it again, that cloth masks are generally not recommended as personal protective equipment, but rather cloth masks serve as source control, that is protecting people around the person wearing the cloth mask from pre or asymptomatic shedding of the virus. However, wearing some form of homemade mask or mouth and nose covering is better than wearing no mask at all. And it's with great regret that this is often a necessary step within some resource constrained settings that we have to use this strategy as opposed to wearing medical grade commercial products. Alternatives to the isolation gowns are not well studied, but again are being used when PPE is limited. So some strategies for obtaining these alternatives are disposable laboratory coats, reusable, that is washable patient gowns or laboratory coats, disposable aprons, and simply clothing that covers the front and the arms that can be then washed and reused. So in summary, healthcare workers obviously and strongly need PPE to reduce their exposure risk to patients at all stages of the cycle of this infection, that is symptomatic, but also asymptomatic and pre-symptomatic spread. If possible, healthcare workers should be enabled to wear gowns, face masks, eye protection, and gloves for patient care, including in non-COVID-19 patient care in transit areas. The priority for PPE should be given to healthcare workers who are performing aerosol generating procedures, who are providing prolonged care with suspect and confirmed cases, and those who are providing high contact care. In resource limited settings, really in all settings, strategies to secure additional PPE, conserve current PPE, and extend the lifespan of PPE can help address gaps in resourcing. When conventional PPE is limited or unavailable, alternatives to medical masks and isolation gowns can be used. And in general, some protection is better than none. There are 3 slides of references, and I do believe that these can be quite helpful to you. Particularly, I find that the World Health Organization rational use of PPE is a useful guidance. In that site are also multiple videos, multiple job aids that you might find useful. You'll see also the Emory videos Emory University videos as 13 and below. So the CDC reference to strategize to optimize the supply of PPE and equipment, I find, again, very practical in my role here, and I think that you will as well. So please take an opportunity to look at that. With that, I think that we can end and see if there are questions that we can take on together.
Thank you, Dr. Talbot. I'd like to invite everyone to submit your questions or comments to the Zoom webinar chat, and I'll read them aloud for Dr. Talbot. Do we have any questions from the audience? Tumame Nagel is asking, could you share the last 3 slides with references, please?
Absolutely. I think that perhaps this may be one of the more important aspects of this, that you can go through and see what works in your own setting. So we're very happy to share these active links and references, and I'm sure Anne will facilitate sending it out immediately.
And I want to let everyone listening today know that we will share materials following this session. Do we have other questions? Patricia Manseri is asking, hi, do lab staff in a hospital protect themselves, especially when performing routine sample processing?
Yes, thank you, Patricia. Indeed, depending on what the laboratorian is doing to the specimen. So again, thankfully, this is not Ebola in terms of its preferred transmission route. So this is droplet. So patient to patient is the highest risk, but fomite contamination can occur. So that's especially relevant in a laboratory. And also aerosol transmission can occur under certain circumstances. In a laboratory, this might mean centrifugation or agitation of a specimen. So yes, laboratorians are suggested to wear face protection. So virtue of face mask, eye protection, gloves, and gown when they are handling and manipulating specimens.
Do we have other questions? I have another question. How should breastfeeding mothers with COVID-19 protect their babies?
What a very good question. So one good bit of research has come out showing that it's not possible to recover the virus from breast milk. So breastfeeding itself is not a mechanism for transmission to an infant, but of course, the positioning of an infant to an infected mother during breastfeeding can be high risk. So we are strongly recommending that mothers wear a cloth face covering or a surgical mask, if at all possible, during breastfeeding or infant care. The other good thing that is emerging, the good recognition is that infants appear to be not predominantly affected by morbidity and mortality from this virus for reasons we don't fully understand. But those at highest risk of being critically ill or even dying from this virus are those older than 60 and those with chronic medical conditions such as diabetes, high blood pressure, or pre-existing heart disease. So generally the mother-infant pair are not particularly vulnerable to severe disease, but it makes sense to everyone to advise that the mother wear a cloth face mask during breastfeeding.
Thank you. I have another question for you. What are recommendations around masking admitted patients?
This is in the spirit of universal masking. So remember, the universal masking is an effort to source control. So for example, if you are admitting a patient with a heart attack or in DKA or with a broken leg, when the epidemic is in a stage of community transmission, you don't know whether that patient is pre-symptomatically asymptomatically or even symptomatically shedding virus. And therefore, universal masking refers to masking everyone in our society, especially prioritizing those in healthcare so that there is not healthcare associated transmission. So an excellent question. We are suggesting universal masking.
Do we have any more questions? I think that's all for questions today. Dr. Talbot, do you have any final comments before we conclude the session?
I do want to recognize that we are in unprecedented times. I know that many of you are in earlier stages of your epidemics, but that we are all impacted by this personally, professionally, economically, and for the long term to come. So I want to just express my, collective condolences that we're in this situation of trying to protect our most vulnerable patients and also ourselves and our colleagues. So I want to wish you very good health and success in your battling this epidemic going forward. So again, thank you for this opportunity to share what we've learned here.
Dr. Talbot, thank you for joining us today, and thank you to everyone who joined us for our first webinar. This is the first of several webinars that we'll be hosting here. We're looking forward to hearing what your needs and priorities are, and we'll plan future webinars accordingly. A copy of this will be posted online, and we will also be sharing resources with everyone who registered for the webinar, both in English and in Spanish. Thanks again to everyone.
Thank you.